Middle cerebral artery supplies motor and sensory cortices for the upper limb and face, the temporal lobe at Wernicke's area, and the frontal lobe at Broca's area. Middle cerebral artery supplies motor and sensory cortices for the upper limb and face, the temporal lobe at Wernicke's area, and the frontal lobe at Broca's area. Infarct causes contralateral paralysis and sensory loss of the face and upper limb, aphasia if the dominant hemisphere is affected, and hemispatial neglect if the non-dominant hemisphere is affected. Wernicke aphasia often presents with right superior quadrantinopia. Anterior cerebral artery supplies motor and sensory cortices of the lower limb. Infarct causes contralateral paralysis and sensory loss of the lower limb and urinary incontinence. Lenticulostriate arteries supply the striatum and internal capsule. Infarct causes pure contralateral paralysis with no cortical signs such as aphasia or visual field deficits. This is the classic lacunar stroke of hypertension. Anterior spinal artery infarct produces medial medullary syndrome. Findings include contralateral paralysis of upper and lower limbs, contralateral loss of proprioception, and ipsilateral hypoglossal dysfunction with tongue deviation toward the lesion. Posterior inferior cerebellar artery infarct produces lateral medullary or Wallenberg syndrome. Findings include dysphagia, hoarseness, loss of gag reflex, hiccups, vomiting, vertigo, nystagmus, decreased pain and temperature from the contralateral body, and ipsilateral face, ipsilateral Horner syndrome, and ipsilateral cerebellar signs such as ataxia and dysmetria. Nucleus ambiguous findings are specific to pica lesions. Anterior inferior cerebellar artery infarct produces lateral pontine syndrome. Facial nucleus involvement causes ipsilateral facial paralysis, decreased lacrimation and salivation, and loss of taste from the anterior two-thirds of the tongue. Additional findings include vomiting, vertigo, nystagmus, decreased pain and temperature from the contralateral body, and ipsilateral face, ipsilateral Horner syndrome, ataxia, dysmetria, and ipsilateral sensorineural deafness. Facial nucleus findings are specific to AICA lesions. Basilar artery infarct affects the pons, medulla, and lower midbrain. Reticular activating system is spared, so consciousness is preserved. Corticospinal and corticobulbar tract damage causes quadriplegia and loss of voluntary facial mouth and tongue movements. Horizontal eye movements are lost, while vertical gaze is preserved. This is locked-in syndrome. Posterior cerebral artery supplies the occipital lobe. Infarct causes contralateral homonymous hemianopsia with macular sparing, and, if dominant hemisphere is involved, alexia without agraphia. Central post-stroke pain syndrome results from thalamic lesions. Initial paresthesias progress to weeks or months of allodynia and dysesthesia on the contralateral side, and occur in about 10% of stroke patients.